the interruption. So now today's lecture is about antipsychotic medicines. So you are now in the mental health module, and you would have learned about various psychiatric illnesses. So now how do we treat these psychiatric illnesses, and what are the medicines available to treat the psychiatric illnesses? So that's what we are going to talk about today. All right. So at the end of this lecture, you should be able to classify the antipsychotic medicines. So what are the groups of antipsychotic medicines that are available to treat psychotic illnesses? So that's the first thing you should know. And then if we broadly categorize antipsychotic medicines, we broadly categorize them into first generation antipsychotic medicines and second generation antipsychotic medicines. So you should be able to explain what first generation antipsychotic medicines are, giving examples and describe their side effects as a group, and then describe second generation or atypical antipsychotics with the examples and describe side effects of the group. And of course, it's very important to know their mechanism of action, indications, contraindications, cautions, side effects, pharmacokinetics, okay? And then also at the end of the lecture, after listening to the features of the first generation antipsychotics and the second generation antipsychotics, you should be able to compare the two groups, giving the advantages and disadvantages of first generation antipsychotics versus second generation antipsychotics. So that is the plan for today's lecture. Okay, now before we talk about psychiatric illnesses, we have to understand what is the way in which our mood is balanced. Now there are so many neurotransmitters in the brain, and some key neurotransmitters that are involved in orderly psychological functions as well as disorganized psychological functions are dopamine, noradrenaline, serotonin. So now when they are in harmony, there's a balanced mood. Okay, but if there is a disharmony, then problems arise. But it's not as simple as that, because it's not like treating a bacterial urinary tract infection caused by E. coli with sensitive antibiotic, because that's very simple. But people actually do not understand why people get psychotic illnesses to begin with. And therefore, people do not also understand very well how to treat psychotic disorders. But through trial and error over the years, now people have seen that some neurotransmitter imbalances are giving patients more a tendency to develop psychiatric illnesses, and also based on that, correcting these neurotransmitters are able to control the psychiatric illnesses. So that is the basis, and nothing is concrete when it comes to psychology or the mind or psychiatric illnesses, as you all know, right? So now you by now would know what are the psychotic illnesses. So in psychotic illnesses, the insight that one is having a psychiatric illness is not there in the patient. So the leading psychiatric disorders are psychotic illnesses are schizophrenia, mania, and depressive psychosis. So now, if we look at the history of patients with psychotic illnesses, so this is the kind of quality of life for patients many bygone years, right? So they had to be tied and isolated because they couldn't stay with their families in the community, and there was no treatment. So there was suffering, and finally death came to them. And then they were again, all people with deranged mental functions were put together, and where it was very harsh, and so they suffered again. So now I'm putting this for you to understand about the importance of now having proper medicines to treat psychiatric illnesses, because we do not realize these things, because now we are fortunate to be in an era where medicines are available to treat patients with psychiatric illnesses. So after that, the first advancement was electroconvulsive therapy to deliver an electric shock and to see whether the deranged chemistry would be corrected. So this is not 100%, as you all know. So that is the progress of the treatment evolution for treatment of psychotic illnesses. So now schizophrenia, the main psychiatric illness, it's due to an increased dopaminergic activity in the limbic structures of the brain, you may know. So why is there an increased dopaminergic activity? It is because there's people think that it may be because there's an increased number of dopamine receptors in the brain, or the available receptors are super sensitive to the dopamine, or there's increased production of dopamine, or reduced destruction of dopamine due to some reason. So again, these are scientific hypotheses, right? So now, based on that, what is the mechanism of action of antipsychotic drugs? Now, these medicines act by interfering with the dopaminergic transmission in the brain by blocking the dopamine D2 receptors. Okay, so these are competitive antagonists of D2 receptors, and they give rise to, therefore, you can now pharmacologically explain this. Now, if the D2 receptors are blocked, then they can get extrapyramidal side effects as well. And also hyperprolactinemia. Can you connect that? Why blocking the dopamine D2 receptors can cause hyperprolactinemia? And also, now these medicines have spillover effect on other receptors like cholinergic, alpha-adrenergic, histaminergic, and serotonin receptors, and therefore, unexpectedly, I mean, we do not want them to cause these adverse effects, but because of the spillover effects and acting on other receptor types, the patients suffer from other adverse effects. Okay, so now what are the indications then for using antipsychotic medicines? So the main indication is prophylaxis and treatment of psychotic illnesses such as schizophrenia. And usually for a schizophrenic patient, the treatment is lifelong. Sometimes psychosis may be associated with depression and mania. Then we use the medicines for them as well. And as an adjunct to benzodiazepines in acutely disturbed patients. So there may be patients who are having alcohol withdrawal or metabolic derangements, having acute agitation. And as an emergency measure, as a short-term measure, sometimes antipsychotic drugs are given as an adjunct to benzodiazepines. Now, these are not the mainstay of treatment for them. And then short-term, to calm disturbed patients, whatever the underlying psychopathology is. So in addition to their true indication, the first line indication, there are some other indications as well, as you can see. So now antipsychotic medicines are not very simple like some other medicine groups. They have a lot of adverse effects, and therefore special patient groups should take more caution, and as a doctor you should have more caution when prescribing antipsychotic medicines to particular patients. For example, those having cardiovascular disease, then Parkinson's disease, epilepsy, depression, myasthenia gravis, prostate hypertrophy. Okay, so now when you listen to the lecture, sometimes understand why these patients, you have to be extra careful. It may be due to their pharmacological mechanism of action. For example, now why you have to be extra careful in patients with Parkinson's disease, you can tell already, isn't it? Because the antipsychotic medicines block the dopamine D2 receptors, and Parkinson's patients are already deficient in dopamine. Therefore, when the drug is given, there's a further reduction, and therefore the symptoms would get worse. Like that, you may be able to tell. And in some patients, the antipsychotic drugs are contraindicated in comatose patients, those with central nervous system depression, and pheochromocytoma. So you can do some homework and try to connect why they are contraindicated in these patients. Okay, so now at the onset, I would like to tell you some practical points about using antipsychotic medicines. One is while on antipsychotic medicines, immediately after starting antipsychotic medicines, you should warn the patients about driving and other skilled tasks because there can be drowsiness that can cause poor performance and also accidents. And also about antipsychotic drug withdrawal. After withdrawing antipsychotic drugs, there's a high risk of relapse. And therefore, it should be done cautiously and gradually rather than abruptly. So after stopping the antipsychotic drugs also, there should be follow-up for 2 years. Okay. And in patients with hepatic impairment, also you have to be cautious because most of the antipsychotic drugs are metabolized in the liver and phenothiazines are hepatotoxic. And therefore, again, you have to, in patients with liver problems, you have to be cautious. And in patients with renal impairment, you have to start with small doses and increase the medicine gradually because even though they are not eliminated unchanged in the kidney except for 1 or 2 medicines, still they can cause cerebral sensitivity due to deranged renal functions. What about pregnancy? Now, if antipsychotic medicines are used in pregnancy, in the baby, there can be extrapyramidal side effects. Okay, if the antipsychotic drugs are used in the 3rd trimester, especially. And what about breastfeeding? Now, there's limited evidence because the clinical trials usually exclude patients who are pregnant or breastfeeding from clinical trials, and therefore the evidence is limited, especially for newer antipsychotic medicines, and therefore you have to refer a formulary like the British National Formulary to get the latest evidence. However, now chronic use of antipsychotic medicines during breastfeeding should be avoided. So in other words, if a breastfeeding mother needs antipsychotic medicines, this is one of the rare instances where we say, then do not breastfeed. What about the pharmacokinetics of antipsychotics in general? They are well absorbed after oral administration. That's good, isn't it? Because then easy administration. It distributes widely and is metabolized mainly by the hepatic cytochrome P450 isoenzymes. Now, amisulpride is an exception to this. This drug is eliminated unchanged by the kidneys. And following intramuscular injections, depot preparations release the drug over 2 to 4 weeks. So there's a very slow, prolonged release of drugs, the medicine from a depot preparation. So that's why we call it a depot preparation, isn't it? When the medicine is there after given intramuscularly in a pool, and then the medicine is released little by little gradually. Okay, so now if I again summarize the history of antipsychotic drug development, now you can see in early 30s, it's the electroconvulsive therapy. And then for several decades, nothing much happened until in 1950s, late 1950s and early 60s, chlorpromazine came to market. And another 1 or 2 decades went before the other drugs were discovered, haloperidol, and so on. And in the 90s, then the newer 2nd generation antipsychotic medicines were developed. And now in the 2000s, now we are talking about another generation, the 3rd generation antipsychotics, and aripiprazole is having a relatively different mechanism of action. So now, classification of antipsychotic medicines. I said there were two broad groups, first generation antipsychotics and second generation antipsychotics. Before we said first and second generation, during our times when we were students, we called them typical antipsychotics and atypical antipsychotics. So what is so typical about the typicals and what is so atypical about the atypicals? People would ask. Okay, so first generation or typical antipsychotics and second generation atypicals. So these are the examples for those. So one very common example for first generation is chlorpromazine, and haloperidol is used quite a lot, and trifluoperazine. And the second generation now, most of these drugs are now being used in the state sector and more so in the private sector. So now let's talk about the first generation antipsychotics. We also call them typical antipsychotic medicines. So first generation, the conventional antipsychotics. Now we also call them neuroleptics. What does that mean? Neuroleptics. So they were first developed in 1950s for the treatment of schizophrenia mainly, and typical antipsychotics were also used for the treatment of acute Sorry, can you hear me?
Yes, madam. Now only we can hear you.
Okay, I was disconnected, but did you hear the previous slide? Did you hear about, did you hear this slide about conventional antipsychotics?
Yes, madam, but not the last line.
Yes, madam. We saw this. Madam, your voice is breaking.
Okay, so now typical antipsychotics are used as well. Okay, so now these are the different chemical classes of the antipsychotic medicines. Okay, can you hear me now?
Yes, madam.
Okay. So now first generation of typical antipsychotic drugs, how do they work? Now we said that they predominantly work by blocking the dopamine D2 receptors in the brain. Okay. So, unfortunately, they are non-selective for the 4 dopamine pathways in the certain dopamine pathways that are responsible for schizophrenia. However, they go and block the 4 dopaminergic pathways in a non-specific manner. Okay, so now if you look at this diagram, the mesolimbic pathway, right? Mesolimbic pathway is responsible for causing the positive symptoms of schizophrenia, right? But now you can see here, there's the nigrostriatal pathway, which is responsible for causing extrapyramidal symptoms, and the tiburohypophyseal pathway, which when the dopamine is blocked, there is hyperprolactinemia. So these pathways are also blocked when the non-specific dopaminergic blocking agents are given, and therefore, in addition to the effect that we want, the effect that we want is to control the positive symptoms of schizophrenia, isn't it? But they go and aggravate the negative symptoms, as well as they go and cause extrapyramidal effects and also cause hyperprolactinemia. So that is a huge problem. So now when we take typical antipsychotic medicines, they are broken down into low potency and high potency classifications. And so for the low potency, under low potency, we have chlorpromazine, and for high potency, we have haloperidol, right? The main drugs that we use commonly. So what is this big issue about high potency and low potency? The high potency typical antipsychotics have more extrapyramidal side effects. However, they have less histamine and alpha-adrenergic anticholinergic side effects. Okay, but if you look at the low potency typical antipsychotics, they have less extrapyramidal side effects, but more histaminergic, alpha-adrenergic, and muscarinic side effects. So that is the difference between high potency and low potency when it comes to the side effect profile. So now, now when we look at the different medicines in the different drug groups, there are different side effects. So antimuscarinic side effects like the dry mouth, blurred vision, constipation, urinary retention. So you must be now very familiar with the antimuscarinic effects. So those things are there. And chlorpromazine has more anticholinergic effects than trifluoperazine and haloperidol. Now you can see chlorpromazine, trifluoperazine, haloperidol, they all belong to the first generation antipsychotics. So they are examples for members of that larger group. However, if you compare these different members, they have differences in their side effect profiles. Now, acute dystonia is again a big issue with typical antipsychotic medicines. And the troublesome, very scary thing is it can sometimes occur a few hours after starting therapy. And then the patients and the caregivers can get very scared, you know. So it's more common in young people, especially males, and when they are on antipsychotics for the first time. So what happens is you may know of acute dystonias where sometimes the neck gets twisted and then the eyes go in one direction and they cannot correct their position, bring the neck and the head to the correct position. And just imagine if that kind of a thing happens soon after taking medicines. So people would be very worried, isn't it? So that is the issue with some of these medicines. So there can be muscle stiffness, muscle cramps, tremors. So those are some neurological side effects. Then extrapyramidal side effects, a cluster of symptoms like Parkinsonism. You would know what happens in Parkinson disease. There is bradykinesia, then rigidity, tremors. So these patients can develop something exactly like idiopathic Parkinson disease. So what would you do if patients develop these things then? Now you all know the etiology, you know, like the dopamine D2 receptor medicines have been given and they are acting non-specifically in all those pathways. and that's the reason for this adverse effects, and there are spillover effects. So based on your understanding about these things, you can select the medicines also to treat the adverse effects. So anticholinergic medicines like benzhexol and benztropine can be used to treat drug-induced Parkinsonism. And sometimes what can be done is reduction of the dose or switching over to a second generation antipsychotic where the extrapyramidal problems are very much less. Okay, in the second generation, it's very much less. So weight gain is another problem with the typical antipsychotic medicines. There is hyperprolactinemia. Now we know that it's due to blocking of the dopamine-mediated prolactin inhibition in the hypothalamic pituitary axis. So now this adverse effect is more likely with first generation compared to second generation as well. Okay, so the patients end up getting various gynecological problems like menstrual irregularities, and there's gynecomastia in males and so on. So now again, what we can do is to reduce the dose or switch over to a second generation. Now, I said that you should be cautious when using antipsychotic medicines in patients with cardiovascular disease. Now we are coming to that point because they have cardiovascular effects themselves. Postural hypotension, prolongation of QT interval, then sedation. So now, because of that, now you can see why we have to be cautious. Okay, so chlorpromazine is more sedating than haloperidol or trifluoroperazine. So chlorpromazine is a drug noted for heavy sedation. And what can we do if one of the antipsychotic medicines that you're interested in giving has sedation? One thing that we can do is start with a lower dose, and the other thing is we can give it at night, so that anyway the risk of sedation during daytime is less. So it can also lead to sexual dysfunctions, and that may be because of reduced dopaminergic transmission and the hyperprolactinemia, anticholinergic effects, and alpha-1 receptor blockade. So all of these things can give rise to this issue. And again, we might have to switch treatment. Now, I want to highlight two very serious adverse effects of the typical antipsychotic medicines. Okay, so are you with me? Can you hear me?
Yes, madam, we can hear you.
Okay, right. Now, these are two very serious side effects. One is tardive dyskinesia. I do not know whether you have heard of this condition, whether you have seen patients with this condition. When you go to psychiatric clinics, and sometimes you meet them in the wards, people who have been on antipsychotics for a long period, they may have developed this serious condition called tardive dyskinesia. So what happens in tardive dyskinesia? How do you recognize tardive dyskinesia? So this is actually the patient has got some involuntary movements of part of their body. And usually it may be the mouth or the tongue where there is a chewing kind of a movement that happens continuously, or there may be various kinds of other repetitive movements. And this occurs after about 2 to 5 years after using the dopamine receptor blocker. And people have postulations for this, why it occurs. One is that there is a paradoxical increase in dopamine sensitivity or activity due to upregulation of receptors. You know that when anything is suppressed, there is a counter mechanism of overcoming that suppression, isn't it? So that is true for the body and the receptors as well. And therefore, there can be a paradoxical increase in the dopamine sensitivity or activity. That's something one hypothesis. And a newer view is that there's some oxidative damage that leads to increase in glutamate transmission, causing this tardive dyskinesia. So whatever the cause is, now the interest is how do you prevent this and how do you manage this, isn't it? So how to prevent this is to use the minimum effective dose, and if it develops, you should try to slowly withdraw that particular neuroleptic. And sometimes you may want to shift over to an atypical antipsychotic like clozapine, where this problem is minimal. And then there are some other mechanisms that are proposed, but they are not anything very much. And actually speaking, the unfortunate situation is that there is no set or standard or effective treatment for tardive dyskinesia. And therefore, the best mechanism or way would be to prevent it if possible, or to identify it early and withdraw the medicine and switch over to some other medicine. And now if the patient is fortunate, it may reverse back to normal, but sometimes it can be for life. So that is one of the serious side effects. Then we have the neuroleptic malignant syndrome. So neuroleptic malignant syndrome, now the word itself suggests malignant. So when you say something is malignant, how do you feel or what do you understand? It's something really dangerous, isn't it? So neuroleptic malignant syndrome is something like that, and it presents as an acute onset of thing where there is high fever and muscle rigidity and autonomic dysfunction in the patient, altered mental status. And so sometimes we may miss this out for bacterial meningoencephalitis or dengue or leptospirosis and not think that it's due to an antipsychotic medicine. And if so, the patient has very poor chance of living. So if this kind of a patient comes, you should think about the possibility of neuroleptic malignant syndrome and try to discontinue the offending agent as much as possible, and supportive care and ICU. And there's some specific treatment like clozapine, bromocriptine, and then electroconvulsive therapy. So typical antipsychotic medicines, these are the ones that are in common use again. So before we start the second part, atypical antipsychotics, any questions? I can give you 1 or 2 minutes for questions. Okay then, so now let's talk about atypical or second generation antipsychotic medicines, okay? So now atypical antipsychotic medicines act on different receptors, and the main receptor is the serotonin 5-HT2 receptor. So they go and block the serotonin 5-HT2 receptors more so than dopamine D2 or D4 receptors compared to the classical agents. Okay? And when they go and block the D2 and D4 receptors, they have a higher affinity for those in the mesolimbic system. So the mesolimbic system, we know, gives rise to the antipsychotic effect. So that is the point we want to block. So that is good, isn't it? So now the atypical agents have a better block of the serotonin 5-HT receptors, and then they are more selective for the D2 and D4 receptors in the mesolimbic system, giving the antipsychotic effects and less effect on the nigrostriatal system, and therefore the extrapyramidal effects are less. atypical. The extrapyramidal effects are less. I'll tell you what those effects are. Anyways, now you can see that there's some improvement here. So then, now the atypical antipsychotics, there's amisulpride, aripiprazole, clozapine, olanzapine, risperidone, and so on. So now, if you take the atypical antipsychotics, how do they compare with the typical antipsychotics or the first generation antipsychotics? So one thing is they are at least as effective as the typical drugs. They are better tolerated and they are less likely to cause extrapyramidal adverse effects, and they are more efficacious for the negative symptoms and cognitive deficits of schizophrenia. Isn't that wonderful? Do you like the atypicals more now? What do you think? Now, I am not a drug medical representative trying to promote atypicals to you, but I'm just telling you these are some benefits. So they are at least as effective, better tolerated, less likely to cause extrapyramidal adverse effects, and more efficacious for negative symptoms and cognitive deficits of schizophrenia. Okay, so that is fine, but what about the side effects? Are the side effects, is the side effect profile better? Unfortunately, they have a lot of metabolic side effects. Weight gain, hyperlipidemia, metabolic syndrome. Now, the thing is, when the patients start on these medicines, they do not come in 1 or 2 days, isn't it? And the patients are very happy, actually, that they tolerate the medicine better and their psychological situation is better. But only after a few months or years now, they start getting the heart attacks and the strokes and obesity and so on, right? So this is something we have to watch out for if you're starting patients on second generation antipsychotics. So hyperprolactinemia, what about that? So compared to the first generation, this is also very much less. So in aripiprazole, clozapine, olanzapine, it's little or none actually. And cardiovascular side effect wise, there's QT prolongation, arrhythmia, sudden death, still it is there. And gastrointestinal disturbances like diarrhea, nausea, vomiting, all those things are still there. Extrapyramidal effects are there, but very much less than in the first generation antipsychotics. So atypical antipsychotics should be used with caution in patients with renal impairment, hepatic impairment, epilepsy, cardiac problems, pregnancy and breastfeeding, blood dysplasias, elderly with dementia, and in those with increased cardiovascular risk. Okay, so because they are very much prone to cause metabolic syndrome and metabolic side effects. So because of this risk of metabolic syndrome, when you start a patient on second generation antipsychotics, you have to monitor carefully for weight gain, blood pressure, plasma glucose, lipid profile, and you should do those at baseline before starting treatment. And then periodically, you have to do those things at regular intervals so that you know that if they are getting deranged, you know it early and you can correct it early. And also you have to advise on diet, good exercise, and therapeutic lifestyle modification. So now I am giving you some further details about a few commonly used second generation antipsychotics. So one is amisulpride. So the strange thing about amisulpride is that there is a dose-dependent variation of action on dopamine receptors. Okay, so at high doses, it has an antipsychotic effect, and at low doses, it is better to control negative symptoms of schizophrenia. Okay, so based on the dose that the patient receives, the effect varies. So now another important thing about amisulpride is its tendency to prolong the QT interval, and therefore the patient can get a predisposition to cardiac arrhythmias. Then what about clozapine? So clozapine also acts on many receptors like dopaminergic, serotonergic, and very many receptors, as you can see in this slide. And adverse effect wise, the worrying things are the blood dysplasias affecting the hemoglobin white cells and platelet depressions, and then metabolic side effects where there's obesity, weight gain, and cardiovascular effects, hypotension, tachycardia, ECG changes, and so sedation is there, and it's also noted to cause neutropenia, especially in some patients. Okay, so those are the issues with clozapine. So myocarditis is another typical side effect of clozapine, for which you have to monitor closely. But now, compared to the typical antipsychotics, this is a drug where you can say it has got superior efficacy. Okay, so now when I compared the first generation and the second generation antipsychotics, I said the second generation antipsychotics were at least as effective as the first generation antipsychotics. Did I tell you that? I did. But now this is a drug, it's not at least as efficacious. It has got superior efficacy. Okay, so but because of its side effects, the myocarditis, the neutropenia, and very troublesome metabolic side effects, it's not given to patients freely, even though it has got superior efficacy. It's used as a reserve medicine to treat treatment-resistant patients and in patients who have a high risk of suicide. Okay, so now if you want to start clozapine, it should be done by a consultant psychiatrist. The patient should be admitted to hospital, so it's not a joke, right? So you have to take good precautions and do baseline investigations and monitor the treatment properly. Okay, so that's clozapine. Now, olanzapine. So again, acts on very many receptors. Excessive weight gain is a problem and it can precipitate type 2 diabetes. Then there can be derangement of liver enzymes. So those are some important side effects of olanzapine. Then quetiapine, again, a range of receptors. So now all the medicines that I'm talking about, they act on very many receptors. So that is a big problem. So it leads to a lot of side effects because of that, right? But now quetiapine is a medicine. Clinical trials have shown that the risk of extrapyramidal adverse effects is minimal. And the prolactin elevation is also minimal. So that is an important thing about quetiapine. Then risperidone is a potent dopamine and serotonin antagonist. And at usual therapeutic doses, it can cause extrapyramidal adverse effects and akathisia. Now, in this medicine, weight gain is not a problem. Okay, so now you can see different members have different characteristics. Now, even the same family, if you take different members, you know, they have some similarities. They carry the same surname and they have some genetic similarities. However, if you take the individual members, there are differences. Like that in this family of atypical antipsychotics also, there are some differences among the members. So there can be cerebrovascular adverse effects as well. Now, risperidone is a medicine which is available as a long-acting depot preparation formulation. So this is important because, you know, sometimes patients with psychotic illnesses, it's very difficult to give them treatment on a daily basis or twice daily basis. So they will sometimes refuse treatment. So then the only option may be to give a depot injection once a month, hoping that they will have some degree of control. However, when you give depot preparations to reach steady state, they take quite long, and therefore sometimes the full effect may not come even up to 5 months. Okay, So then aripiprazole. Now some people think that this is a third generation antipsychotic. Okay, so why is that? The mechanism of action differs in aripiprazole compared to the other antipsychotics. What does that mean? Now, all the other antipsychotic medicines affected the dopamine D2 receptors. So that's how they work. So they were dopamine receptor antagonists. What about aripiprazole? Aripiprazole is a dopamine D2 partial agonist. Okay, so what does that mean? So, what does that mean? At a lower dose, so it will have some agonist effect, isn't it? But when the dopamine concentration in the brain is high, it has a antagonist effect. So when the dopamine concentration in the brain is high and the psychotic symptoms are there in a patient, this the partial agonist acts as an antagonist because the dopamine in the brain is the full agonist in that situation. So aripiprazole will become the partial agonist, and therefore, in fact, it's like an antagonist. So it suppresses the dopamine in a the dopamine concentration related manner. So that because of that, the better and smooth. Okay. So now scientists are going on discovering newer antipsychotic medicines. Now, several other medicines have now come to market. So they are also D2 receptor antagonists. And so they reduce the positive symptoms of schizophrenia and so they have reduced extrapyramidal effects. So now look at this table. Now, this table compares some adverse effects of atypical antipsychotics and typical antipsychotics. What the adverse effects are: extrapyramidal, sedation, weight gain, hyperglycemia, anticholinergic, and orthostatic hypotension. Now, if you look at this table, which antipsychotic is the best? What do you think? Side effect profile wise, which antipsychotic is the best? Isuru Tarinder, which one do you think is the best? Isuru? Now the green is the best, yellow is intermediate. If it's red, the side effect is bad. Several cycles are there, right? So now side effects wise, which one is the best one with the least amount of side effects? Looking at this table. Huh? Are you all asleep? Isuru, can you hear me?
Yes, madam.
So which one would you select as the one with the least side effects?
It's aripiprazole.
Yeah, that's right. Isn't it aripiprazole? Because you can see there are two greens and the others are yellow. So the adverse effect, the given adverse effect is negligible or absent or infrequent in aripiprazole, this newer, what we call the third generation antipsychotic, right? After that, what do you think is the next best? Right? So amisulpride, isn't it? So like that, you can compare the side effects of different antipsychotics. Now look at olanzapine. The sedation is very high, weight gain, hyperglycemia, my goodness, anticholinergic effects, a lot of side effects, isn't it? Clozapine is the same. Now look at this one, chlorpromazine. Sedation, weight gain, hyperglycemia, anticholinergic, you name it, it has it, like, isn't it? So the side effects wise, a lot of side effects. So now based on all these, when you're selecting an antipsychotic for your patient, you have to think of the side effects as well. Now, if sedation is going to be a big problem for your patient, right? Let's say an airline pilot. So you have to think, and I don't know whether he will be able to be an airline pilot with all this. But I mean, if they are doing some high risk work, you have to select the one with least sedation, isn't it? So aripiprazole is the best choice, if so. Weight gain wise, also aripiprazole is the best choice. So extrapyramidal side effects wise, clozapine is the best choice and risperidone is the worst choice, right? So like that, you have to select the particular antipsychotics in your patient. So now, looking at this slide, you can see how there is a shift from the first generation antipsychotics to second generation antipsychotics, side effects wise. Now, in the first generation antipsychotics, you can see this huge orange circle of extrapyramidal side effects and tardive dyskinesia. Whereas now in the second generation, what are the big circles? Weight gain, diabetes, dyslipidemia, insulin resistance, cardiovascular effects, hyperglycemia. So long term, even these side effects are going to affect the patients a lot, isn't it? So now, some principles of antipsychotic drug administration, therefore, start with the lowest possible dose, and the increase should be gradual, right? If the patient does not have adequate response in 2 weeks, you can increase the dose further. And then there's a maximum dose to which you can increase it. And usually antipsychotic drugs are administered once daily because they have long half-lives. Now, if the response is inadequate after doing all that, then the medicine can be changed to another one gradually. A word about depot injections. Now, depot injections are esterified forms of the parent drug dissolved in an oily medium, and when administered intramuscularly, it's absorbed slowly over a prolonged period of few weeks. Okay, so depot preparations are available for several medicines, so that they can be given to patients usually when the patients are not compliant with treatment, and it's used for involuntary community treatment where the patients either the treating team goes to the patient or the patient is brought to the hospital. Sometimes actually even it will have to be done with police escort at times. So anyway, it's for that kind of patient that depot injections are usually given, and it's limited to high potency antipsychotics usually, and it usually you do not start a patient with depot preparations. You try to give once daily medicines, but if the patient doesn't comply only, we have to think of other alternatives like depot preparations. So there are first generation depot preparations and second generation depot preparations as well. Now, antipsychotic medicines are administered for some other purposes also. One is to settle or rapid tranquilization of acutely agitated patients. And for this purpose, we use the intramuscular route. And there are some preferred drugs for this purpose, like chlorpromazine and haloperidol. And in the second generation also, there are some drugs like olanzapine. So now, therefore, you can see that antipsychotic medicines, their main indication is to treat psychotic illnesses. The main one is schizophrenia or psychotic depression and so on. But they have some other indications as well and for rapid tranquilization of acutely disturbed patients. So they are a group where we have to use it for the proper indications and monitor the patients for the side effects. And most of this lecture, I have been talking to you about the side effects of the antipsychotics more than the effects. Because if you compare effect-wise, the effect-wise, they are more or less the same. But the advantages of classical versus atypical antipsychotics, there are three main areas. The atypical antipsychotics, they are more tolerable and the compliance is better. You would understand that now because the extrapyramidal syndrome is much less with the second generation antipsychotic. Just imagine now, if you give an antipsychotic, the psychotic component will settle, but if the patient can't move at all at the end of it and having a tremor and rigidity, so the quality of life is not going to be any better, right? So atypical antipsychotics are very much better that way. And greater efficacy against negative symptoms of schizophrenia, that's the next advantage of atypical antipsychotics. And clozapine, as I told you before, is more effective than typical antipsychotics for treatment-resistant schizophrenia. Okay, so this is a comparison about the advantages of classical versus atypical antipsychotic medicines. Okay, so we have come to the end of the lecture and there's 1 minute left if you want to ask any questions. Sorry about the disturbances, which was beyond me because of the power cuts and the Zoom connection issues. So, and I know that you all are also having the same issue. Some of you can't log in because of the power cuts. So we are having it uploaded, the PDF to the LMS and also the recording. I don't know whether the recording was continuous today. So if there's anything, you can contact me afterwards also and clarify. Okay, then, thank you very much. Take care. Bye.
Thank you, madam.
Recording stopped.